Thank you very much. I'm going to talk about slightly different things, although we're all pointing in the same direction. I'm talking about data and statistics a little bit. So data, when I'm talking about big data, I mean, I'm not using the word, but for the sake of the presentation, I am. But what I mean is there are a lot of data out there you can use for trials. So I'm going beyond the traditional concept of a twig where you have a prospective cohort, you ask people to come regularly for a follow-up measurements and use that for your twigs. I'm talking about another scenario where you utilize routinely collected data. I'll give two examples. One is you go to your general practitioner. You have diabetes. Your GP approaches you and says, are you willing to be randomized to this new intervention? And that's basically it, because your GP, your electronic health records, will know whether you get a heart attack, whether you die, etc., etc. So you actually don't need any follow-up visits. It could be the ideal simple trial in that respect. Another example, your smartphones or your phones. Google could easily text a few of you with information about going to Amazon and doing some shopping. They'll also be able to actually measure for all of us whether we use Amazon or not. So that's another example of a twig study where you can utilize routinely collected data quite easily. And that points to the earlier discussion with Sean about kind of efficiency. We could make trials much simpler if we utilize all the data out there which are already being collected. So that's what I will talk. And this is just an outline of all the data that are already out there. Genetic data, your data from your general practitioner, your phone, your data on your watch pedometer, measuring where you go, your smartphone, etc., etc. There's a lot of information out there which is being collected at the moment. This is just talking about primary care. I had that little clip, but I don't think the technology works. But if you go to your GP in the UK, they basically utilize electronic health records. Everything is being entered into your system. And it's been in place for about 20, 30 years now in the UK. So there's a wealth of information in there and about 4 different systems. And I've done a lot of research utilizing those data for research. So we've talked about that already a lot, explanatory trials and pragmatic trials. And my definition of pragmatic trials is actually you try to replicate usual care. That's the ideal. Everything is as you would normally do, with the exception you randomize. That would be the ideal. If you talk about medicines, there are no such thing as pragmatic trials. I was involved in a study comparing 2 different statins in general practice. So the only thing the GP needed to do, ask the patient for consent, are you willing to be randomized between 2 widely used statins, used by millions of patients. But no, before we can actually do the study, the poor GP had to complete training on how to prescribe a statin. So these guys had prescribed statin to thousands of patients individually. But no, still the piece of paper needed to show I have been trained in statin prescribing. They also had to do good clinical practice training, whatever that means. So they had to learn about how to store a medicine, totally irrelevant in this case, etc., etc. So in the end, what we started with 400 enthusiastic GPs, and we ended up with 17 GPs who participated in the trial. A huge inefficiency, because actually the 400 of them said, yes, we're interested in doing the studies. We like the study, these are our patients, these are our interventions, but the moment you came with paperwork, they all ran away. This is my pictorial representation of pragmatic trials and explanatory trial. This is for the drug Ferrari. Carefully monitored, carefully selected patients, etc. And then we all generalized most widely to routine care and I started applying this wonderful drug in very diverse situations with very diverse patients, as you can see here. And we don't seem to be worried at all about generalizing from these highly selective trials to daily practice. The regulators don't seem to give too much thought about that, which I think is a real challenge. So people have been talking about it, and Andrew, I forgot where he's sitting, but there, he also mentioned that we actually need to simplify trials, and that's why I think twigs are so attractive. We need to have much simpler eligibility criteria, and we actually need to start using the data we're already collecting on a day-to-day basis. Simpler designs like twigs, and also thinking about different consent models. And an interesting comment about Janet Wisely, who's the head of the ethics committee, the Health Research Agency. She pointed out that the data we need for a trial are also data we need in routine clinical practice. They are not opposite. A clinician wants to know whether the patient suffers a heart attack. A clinical trial also wants to know that. So actually, we need to integrate much more research into day-to-day practice. So I've been involved in some work where we're trying to do that, utilize all those data from routine care, electronic health records. And this is a paper we written a couple of years ago in the BMJ. So we set up this system where basically in general practice the GP approached the patient, and general practitioners in the UK all use electronic health records. That's here. And basically there was a system where all these data were downloaded to the research database, minus the patient identifier. So they were anonymous data. And in that database, we could identify potentially eligible patients. Let's say patients who have a high risk of cardiovascular disease and who are eligible for statins. So their patient numbers were fed back to that electronic health record, to the desktop where the GP was working. And basically whenever that patient on our list visited the GP, a pop-up box could appear and basically say, this patient is eligible for the trial. You can either approach the patient, you can ask the patient for consent, or you can tell the pop-up to go away. And if the GP said, yes, I'm willing to recruit the patient for the trial, the eligibility was confirmed, and that more or less was the end of the trial. Because we then utilize all those data from the routine clinical practice for following the patient. So for respect to tricks, what you can do, you can identify in your research database, for example, all your patients with diabetes of a certain age range. And then you randomly pick a subgroup and say, you're offering the new intervention to them, you call them to the practice or whatever, you ask them and they can enroll them in a new intervention, and then you can follow patients using those routinely collected data. You have your usual care arm, you're not doing anything with them, and you have your active intervention arm as well. So that's one way of doing trials, and we were able to link that GP database to other databases. Of course, you need all kind of approvals for that, but that allowed us to also pick up data which were collected in hospitals, so hospital admission data, and also death certificate data. So you basically have a long-term follow-up. So the study was finished, let's say, a couple of years ago. Actually, we're still collecting data on those patients. So we could go back and see what's happening to those patients. This is another example from a very simple trial which actually followed more or less the same principle. This was based on the disease registry. This is a large trial in Sweden. Cardiologists basically routinely give data to a registry in order to compare their performance versus other clinics. And they already routinely do that on a day-to-day basis. So each patient who comes to their clinic, they enter information into that. So in this trial, basically, the patients were randomized with their consent between two different interventions. And then the data from the registry was used to follow patients. So this was a trial which about 6,000 patients enrolled. And I think almost 90% or so of all clinics in Sweden participated in the trial. And the trial cost a grand total of 400,000 euros. A comparable trial academic trial would cost 20, 30, 40 million. If it would be an industry-sponsored study, it probably would cost 200 million. So you can see the inefficiency. And these were very relevant outcomes. Mortality, you don't need to send a research nurse to the site to collect data. There are other ways of collecting the information as well. Of course, there are challenges with routinely collected data, and I can talk for a very long time about that, but also opportunities. But there are challenges. There's quality of data. So, for example, not the data of an electronic health records and other sources is not always perfect. There are sometimes data not recorded, but the important thing is you can look at the data and you can determine before you start a trial whether the data are adequate or not. And in addition, you can develop algorithms, you can develop approaches which you can show where you can assess outcomes or not. And the advantage of having electronic data is you can reproduce it. So if you develop an algorithm, you can reapply it 5 years later, etc. Another element, of course, is completeness of data. You not always have the data you're interested in. So what approach we used in our trial, we went through the database and we picked up the sites which had good data. And we removed the sites which had poor data recording. So that's one approach of restricting your site to your study to the site with good data. A linkage to other data sources, like I said, to the hospital data, to the death certificate data, allows you to do long-term follow-up and allows you also to pick up events which were not caught by the GP. An important question always is about blinding. People say, oh, with your trials, your pragmatic trials, your tricks trial is not blinded. The answer to that is actually depends on the outcome you're interested in. If you have a major clinical outcome like a heart attack or a death, unlikely blinding would make any difference. It is not as if a physician looks at a dead patient and says, oh, you are on a statin, therefore I'm changing my diagnosis of death. So blinding is important with more subjective outcomes. With hard clinical outcomes, it's much less important. Plus also what you can do is you can basically blind your statisticians. You can blind the outcome assessors to the treatment allocation. That's called the probe design. So that's these challenges. But this is just an example of the kind of the challenge we face in current trials. But we are blinded. We say this is gold standard. But what we do in current trials, we have this source record, which is has almost mythical considerations in our current blinded trials, and we transpose that on this beautiful organized case report form, and we say that's the gold standard study. Well, actually, the source data are crap, but no one talks about that. We all say, oh, this beautiful case report form, look how well this gold standard study does. But the moment, of course, you go to electronic data, the messiness is there. Everyone can look at an electronic health record and say, oh, this coding is pretty inadequate. No one says it about paper records because researchers don't have access to it. But there's an opportunity though, because you can develop algorithms, you can develop approaches where you can basically outline how you've done it. Your research can become reproducible. With paper records, it's not reproducible. No one can reproduce what you've done. How the information ended up in case report form is utterly unclear. You can do that with digital data. So just going back to tricks, so basically, I'm not outlining the design, but I'm just talking about. Just want to touch on some challenges statistical challenges with this design. As we discussed, which of course is that treatment refusal only happens in one arm, and which is the new intervention arm. And the challenge there is that there can be bias because you may have refusal or non-uptake in one arm only, and I'm going to talk about that a bit more. The second challenge is that your usual care arm can be very diverse. In a sense, you may have multiple treatments that compose of usual care in the control arm. So you're comparing your new intervention with a mixed bag of interventions. And then the other thing is your intervention arm, your new intervention arm, maybe people starting a new treatment, while your usual care arm will be a mix of people starting treatments and people already on treatment for a long time. And then the last thing was comments I've heard when I presented things like Twix. People are always very interested in Twix because, of course, it is very efficient. You only need to do something with your new intervention arm. But they said it's unethical for lack of consent, guinea pigs, etc. And that's one of the issues we discussed this morning in detail. People are quite kind of hesitant about having a control arm, usual care arm, without consent. So just touching on kind of this issue of kind of you have your new intervention and you have your usual care arm. And I'll give the example of diabetes. So you basically identify patients with diabetes within the general practice, let's say, and you identify, then randomly sample a couple of them and offer them a new intervention. The challenge is your new intervention will all be people starting this new intervention, while the rest of your usual care arm will be people who have been on treatment for quite a long time. And that's called the difference between incident patient and prevalent users. And in some cases it may not matter, but this is a study done in Scotland. This was a study comparing celecoxib versus, that's a newer NSAID versus older NSAIDs. And what they found is that people who basically people were either randomized continuing their traditional NSAIDs, have been on that drug for many years, or starting this new drug. So they were comparing incident users versus prevalent users. And they found that people who were in the celecoxib arm, they were all starting new treatment, quite a few of them suffered side effects. And we often, you see that, people start a new treatment, quite a few people experience side effects in the early on. And the people who continue are basically survivors. They basically tolerate the drug. And they found that in this trial. So that's a potential limitation of the Twix design. Another thing is we done some work, and Alexander Pate is there, about the issues of non-uptake in the intervention arm. So we talked about that. So we only have one arm in which patients can say no, and that can potentially lead to bias and loss of power. So we did some statistical simulation work around that, and I'll try to explain that. So basically, the first row is basically the difference with the real effect. So you have a simulation, you put a certain effect, you do a Twix trial, and you know your true effect. That's 0. And then the power is you basically have a 0.8, 80% power is what the simulation was powered to. Anything below that, you lose power. And this is to do with loss of uptake. So you have different scenarios here. One is 10% of your patient in your new intervention group say no, 20% and 30%. And in addition to that, you have different levels of patients who say no. You have patients who say, oh, the 10% of patients who say no, all randomly, basically a random subset. If you go to this end, the patients who say no are the patients at high risk of the outcome. So you have a kind of a non-random dropout or non-random refusal. So this is what we then try to assess. And the different statistical techniques, ITT, intention to treat. Then there's per protocol, which is the green one, and then there are two instrumental variable techniques. So instrumental variable are a statistical technique which supposedly should address all those issues. And of course, so what you can see is that intent to treat leads to a difference. And one can argue that, yes, there's non-uptake, that's what you would normally have anyhow. The challenge, of course, in a TRIX, and if you have a research setting, that non-uptake may be larger than you would normally have. So that's, of course, the challenge. How different are you in a TRIX compared to your usual care setting? But you can see here that in all the different scenarios and all the different statistical approaches, you will find quite a few of the different techniques are actually not capturing the true effect. So you have a potential bias there. The second issue you can see that on the latter row is that you basically can also see that except for the per protocol analysis, all the other techniques lead to a loss of power. So if you have non-uptake, your statistical power drops, and also there may be potential bias in your treatment estimate. So basically what was concluded that the ITT effect is actually basically will be somewhere, you don't know where, between the ITT and instrumental variable estimate, and the key question you always will have is the dropout I'm seeing in TRIX different from usual care or not? And the other recommendation we made because of the loss of power is we basically said you need to have an adaptive power calculation, an adaptive sample size. If you see a lot of patients are dropping out early on, you may have to consider expanding, increasing the number of patients, or you may have to consider switching to more traditional trial. So just briefly, the other challenge is, of course, this usual care. So you have various treatments in your usual care arms, let's say treatment A1 and treatment 2. Of course, the comparison between new treatment and usual care overall is random, but if you may have the interest comparing the new treatment versus treatment 1 and versus treatment 2. You want to make individual comparisons. And we did some work showing that actually there may be a potential bias there. Because let's say treatment 1 is all used by women, control treatment 2 is all used by men. Of course, this treatment new, composing of a mix of men and women, comparing men and women to women only, leads to a bias. So we did some work around that, and we basically, here is an example. If you know everything about this heterogeneity, it's known, you can adjust for that. There's different statistical techniques. I'm not going into detail, like propensity scores, instruments to variable, you can adjust for that. And here you can see that what you basically, after adjustment, you will get very close to the real effect. But the moment all this heterogeneity is unknown, you can't measure it, you get a bias. You get a bias comparing the new treatment to the individual treatment. So that's why there's a challenge. If you do a TRIX where the usual care arm consists of various treatments, you have difficulty comparing the new intervention versus the individual treatments. There are statistical issues with that. So my conclusion is actually TRIX are a very attractive design, especially in this era of big data, in which I mean there are lots of data out there we can utilize for trials. But there are challenges. It's the lack of uptake of the new intervention, which can potentially bias the results and also leads to the loss of power. And also if your usual care is a very mixed bag, you will have challenges in making individual comparisons. Any questions?
I had difficulty following all the assumptions that went into the simulations, but am I correct, you made that assumption that the non-uptake would be larger in TRIX than in standard RCTs? Where does that come from?
I mean, that assumption is untestable because we don't know. It's one of those things we don't know whether it is or it isn't. That's of course the main challenge. The other challenge, of course, if you uptake let's say if the people refusing to take part in your new intervention are very different from the ones who are taking part, you also get a bias because of that. So that's the other thing, is that are the people who are refusing, are they the same or not? So there are two issues there.
Yeah, but I mean, you clearly demonstrated that non-uptake causes bias, but I didn't get where the trial design makes difference.
I mean, that's one of the challenges we don't know, is that whether we actually, how much we affect. The only thing is we do know is if you make things very complex, consent procedures, etc., your uptake generally drops down quite a bit.
Sure.
I'm pretty sure I didn't follow correctly your bias argument, but so this question may be very misplaced, but I'm not understanding why failure to take the drug in the intervention arm is not viewed as pragmatic, and therefore an ITT analysis is the definitive pragmatic analysis. It's that. I mean, it's this one. Let's take the top line. Yeah. So what I'm trying to understand is, I understand that people in the intervention arm failed to take the drug. I even understood, I think, that those people may be different. That the people who don't take the drug are perhaps the older people. Yeah. Okay. But I'm not understanding why that's relevant at all. Why is it not just pragmatic?
So of course people don't take the drug in normal practice. I totally agree. So then your ITT analysis is what you would do. The only question, the only issue is, or the two issues, one is actually this not, is your non-uptake, your non-compliance not higher in a research setting, a TWIG setting, compared to usual care? That's the key question. And I don't know the answer to that, but it's a major concern if, let's say, 50% of your patients say no to your new intervention.
That's a point of clarification. Are we talking about non-adherence here, or
No, this is non-uptake.
We're talking about declining.
This is non-uptake. This is This is non-uptake.
So about non-uptake, could you just explain what you mean?
But that is in a sense, so let's say you have a cohort of diabetics. You have 1,000 diabetics. You randomly sample 100 for your new intervention. And you approach the patient and say, we now want to give you this new intervention. And 50 of those 100 patients say, I don't want to I don't want to participate. I'm not talking about later non-uptake, non-compliance. I'm talking about non-uptake. So and if your trial is basically in a normal setting, if your GP approaches you and say, I have this drug, I want to treat you because you're not doing well, most patients will say yes. You do it in a research setting with lots of consent forms, etc. A lot more patients say no. That's what I'm talking about.
Of course, in normal randomized trials, that 50% who refuse to join are invisible because we don't look at them. So this at least makes them visible.
It makes not necessarily makes them. It doesn't make them visible.
Well, you have the same. You know who you approached, and you know who agreed.
Yeah.
And you have
that makes them visible, and you have cohort data on them because they've agreed to be in the cohort. Yeah. So. I'm still not understanding the bias issue.
If 50%, let's say 50% of your patients in a TWIG style say no to the new intervention, while in normal practice, let's say only 5% refuse a treatment.
You mean normal research practice?
No, normal practice. I'm talking about normal clinical practice.
Could you define new intervention? Because that's what we're talking about. If it's new, unapproved intervention.
No, I'm not worried. This is a pragmatic setting, so you would not deal with unlicensed medication.
Right, so what do you mean by new?
Okay, I'll give an example. So you have all your diabetics. So they're getting a range of treatments. You have a medicine which is approved, which is basically new. It's an approved medicine.
New approved drug.
Yeah, new approved drug.
Got it.
Yeah, so that's an example. So you then want to do a TWIG. So you want to randomly sample a few out of them and say, I'm looked at your data, I want to give you this new one. It's been approved, and then you want to do your trial. That's the scenario as an example. That's while if the GP would be doing an outside trial setting, they would call on the patient and say, I want to prescribe you this. Here it is. That's the two different scenarios. Does it explain it, or?
Well, it's clear to me that there might be a problem if the refusal rate is different for a new approved drug in a Twix than it is in usual practice. My sense is that the Twix is so embedded in usual practice that it's very hard to understand why it would look any different from usual practice and why the assumed, why the sort of default assumption is that it might be different. It is for usual practice.
Does your analysis assume some kind of association between refusal and baseline patient characteristics?
Yeah, you also make an assumption there. But
So if it was purely non-differential, I think it wouldn't matter, would it?
unless your refusal rates become quite large. The key is your refusal as you would normally encounter, or it's very different. And that's where the challenge is. If you have additional consent procedure, then you get into a scenario that it could be very, very different. That's the point.
Okay, there's all kinds of subtle hints that we're supposed to move on.